Good morning. Welcome to the Transitions of Care Project Team webinar. This is Colleen Florio at Adirondack Health Institute. We had a little trouble dialing in, and I'm wondering if some participants may have run into the same issue. As such, I'm seeing a few more join. We'll start in 1 more minute. Okay, welcome everybody. It looks like most of the registrants have joined, so we'll begin the Transitions of Care webinar. On the webinar today, I'll give you a quick overview of the project goals and implementations. We'll speak briefly about the requirements and how those requirements connect to a work plan, as well as when that work plan is due. We'll spend most of the time on project speed and scale, as well as project budget, since those two items do have a deadline on March 13th. Okay, so the Transitions of Care team has been established to cover 2 projects. Project 2B8, Hospital to Home Collaboration Solutions, and Project 3GI, to increase access to palliative care programs in patient-centered medical homes. It was our thinking that these 2 programs, these 2 projects probably share team members, and there's a lot of potential for overlap, and we thought it would be helpful to have one team address these 2 projects. Within each region, we'd like each project implementation to have a leader, to complete a work plan, complete a speed and scale template, and complete a project budget. Many of you already have designated leaders for these projects. So it varied a little bit from region to region how the regional health innovation teams structured themselves. But in most areas, there was either a subcommittee that worked specifically on each of these projects, or at least there was someone who really led the effort to develop the project in that region. So I think most of you already would know who that leader is for each of these projects. Overall, it's the goal that we have one PPS level work plan for each project. However, getting to that high level work plan that's consistent for the entire PPS will be a process, and at this point in time, I'm suggesting that each region may want to do their own work plan, and we then take a look at those plans and determine what's in common across the regions. That's just a suggestion for how we get to that high-level work plan. We could work with you as a team to go straight to that high-level plan and not start with the project-specific ones. I think we'll address that more during the question and answer. I'd like to hear your thoughts on that. there is time, as you'll see in a minute, there is more time to get the work plan done than the next two pieces. So those next two pieces, the speed and scale template, as well as the project budget, those are items that we would need from each project implementation within each region to submit. When it comes to work planning, as I said, the work plan is really a high-level outline of the steps that are needed to meet each project requirement and milestone. The project requirements and milestones have been set by DOH. They haven't changed since we looked at them when we worked together on project planning last November and December. What will happen with that work plan is that the work plan will, the steps that we are submitted as part of the work plan, each step will become part of the overall work plan that's put into the DSRIP tracker. Some of you saw a demo of the DSRIP tracker at a meeting in Lake Placid. Others haven't seen it yet. But what the DSRIP tracker is it's a tool for network partners and for the project managers to use to look at our status against the requirements and milestones, provide documentation that shows that those have been met, and overall monitor the progress on the project. So again, the goal is one PPS level work plan for each project. At this point, if the team opts to go this direction, each implementation in each region could submit their own work plan to AHI by April 22nd. Alternatively, if you opt as a team to meet a few times between now and then and compile that work plan at the high level, a single work plan that serves the entire PPS, we can facilitate those meetings if you'd like to go in that direction. The template will be distributed March 6th, so later this week we'll post on the blog the template for you to use to create that work plan. For anyone who wants to look at that original document again that shows you the DOH required project requirements, milestones, and metrics, the link to that PDF is given on the screen. And the work plan template that you'll be receiving on the 6th simply shows those same requirements and milestones that are in the document, and there's just a space underneath them where you'll put in steps that it takes to get to those requirements, as well as a target date and a person responsible for each of those steps. So that's work planning. Since the work plans are not due until April 22nd, we do have a little bit more time to develop those. Just wanted to mention why that date is later. The reason that those are not due until April 22nd is because while we need those plans to show that we have our steps in place and we'll monitor those steps in the DSRIP tracker, what we don't need is we don't need to submit those work plans for the April 1st submission to the Department of Health. So many of you are aware that April 1st is the due date for the PPS to submit an implementation plan to DOH. We had anticipated a need for detailed work plans with that submission, but that is not the case. So the work plans are not, there is no work plan submitted, and there's not a work plan for the April 1st submission. So we have more time to do those. It does feel a little backwards because we still have to do speed and scale and budget, even though we don't have to do work plans yet. So we'll turn it over now to the topic of project speed and scale. The project speed and scale template will be completed by each project implementation within each region, and it'll be due back on March 13th. The email address for where to submit is shown on the slide. You'll simply submit it with the subject line, speed and scale. We'll take a look at the actual template in a moment. It's on an upcoming slide. Some of the directions you'll see on the screen here. When we look at that speed and scale template, you'll see that there's a box where you can indicate the quarter by the end of which all the project requirements will have been met by your team. In addition, there's a spot where you will complete the expected number of actively engaged patients by quarter. On the template, you'll see some red numbers. Those are the speed and scale commitments that we've already made. So in January, the PPS had to submit project speed and scale commitments. We took the information that you had submitted to us on your project templates last December. We took that information, we evaluated it, we knew there were a lot of things that were unclear at the time you did those projections. So we compiled those numbers and we came up with speed and scale commitments that we submitted in January. Many of you asked if you could just reference those numbers that you already submitted as you develop your speed, as you kind of develop these quarterly speed and scale commitments, and you certainly can if those are useful to you. We've taken the templates that you submitted before and have put them together into one document. So every region's previously submitted numbers are together and in a single document, and that document, in addition to the template, will be posted on our website, on the blog. So before we look at the template, just a few more pieces of information to help you understand the task. On the template, you're projecting the number of actively engaged patients by quarter. The definitions for actively engaged are specific to each project. So for the hospital to home project, actively engaged is defined as the number of patients who avoided home care to hospital transfer attributable to Interact-like principles. You may be wondering how we're going to measure that, and I am too. So we do not have details right now on the measurement methodology for that particular definition. Overall, we know that DOH has said that any actively engaged definition that can be measured through claims data will be measured through claims data, but this particular one, I'm not sure how they're going to operationalize that definition and how we'll be doing that counting. For palliative, the palliative project, the actively engaged definition is the number of participating patients that receive palliative care procedures at participating sites. So in order to complete the scale section of the speed and scale template, we have to apply the appropriate counting methodology. The transitions of care projects, the two that we're discussing today, both use counting methodology 3. Counting methodology 3 is a count of patients that meet the criteria over a 1-year measurement period, and duplicate counts of patients are not allowed within a given year, and the count is not additive across DSRIP years. So this slide gives an example of how to apply this particular counting methodology. In the project speed and scale template that you receive, you will only be completing a row that says number of actively engaged patients. So the expected in the percent you don't need to fill out. You'll see the template in a second, and you'll just fill out your projected numbers excuse me, of actively engaged patients. So I know this is a little difficult, little difficult to read, but the actual template itself will be posted on our blog. And let's take a look first at the top at the project implementation speed section of the table. What you'll see is there is a red X under project implementation speed for DSRIP year 3, quarter 4. What that red X means is that that's the point in time that the PPS network has already committed in our January speed and scale submission. We committed that by that point in time, all of the participating partners will have met all of the project requirements. What we need from you now, what you'll see on your template, is we have a list of participating partners or sites in each project, and what you're asked to do is consider the project requirements. Again, the link was shown on the previous slide, and those requirements will also be listed out in the work plan. Take a look at those requirements and determine at what point in time your organization will have met all of the project requirements. We have to show that all of the participating partners or sites have done so no later than where you see that red X. But what the Department of Health would like to see is that we're not kind of having everybody meet all those requirements at the very end, but rather that some sites or some partners are getting going earlier than others, and that there's kind of a phased implementation across the PPS. We're not dictating to you what that phased-in approach looks like. We're just asking you if you want to make a commitment earlier than that red X to go ahead and make that commitment now. And again, some of you may have already made commitments earlier than that red X back when you did your templates, and this is your opportunity to kind of revisit that and see if that's really realistic or not. So you do have the opportunity to modify what you had put in when you submitted templates last December. And again, the information you submitted last December is available in summary form that'll be posted on the blog. And then similarly, specific to your agency or to your site, we're looking for you to project the number of patients engaged. You'll have on your summary the information that you submitted before, but the counting methodologies actually were not even made clear to us until early January. So I think that you may want to reconsider those numbers and do some new projections. The numbers that you see in red are the numbers that we submitted in January. At that point in time, we had to submit a single rolled up number for the PPS as a whole, and we were asked to submit that in 6-month periods. So that's why it's blank in between the 6-month periods. What we need now is to actually submit them on a quarterly basis, and we'd like to show the commitments by site or by partner, as you see down the side. One thing to keep in mind is that when we made the commitments in January, we were advised to be conservative. The achievement of these numbers is tied to the payment methodology, and we projected as conservative of a number as we thought would be reasonable. Our project still scored well, so we're happy with that. And at this point in time, I would think of these as a minimum number that we're trying to meet as a PPS as a whole. So if they may look very low to you, that's okay. We're not. It doesn't hurt us to have a low number committed to. We need to achieve that number as part of the payment, and if in fact we exceed those numbers, there are some opportunities to receive bonus payments from a high performance fund. So I would encourage each organization that's participating in this implementation to revisit your numbers, look carefully at what projections you can make now that you have that definition as well as the counting methodology more clear, and you'll send back to us that template with your actively engaged patient commitments shown on a quarterly basis. It's important to remember with this counting methodology that basically you can think of it as that it resets to 0 at the start of any given year. So to kind of walk you through it, what you see is that by the end of the second quarter of DSRIP year 2, so that would be by the end of June, by the end of the second quarter of DSRIP year 2, a little over 1,000 patients will have met the actively engaged criteria. I'm getting a message on my screen that says the audio connection's lost. Let's try it again. I'm not sure if you can hear me. We're having some technical difficulties with the audio. Another window is on top of it. Please move this window. I believe our audio connection has been restored. I apologize for the disruption there, and I'm actually not sure exactly when it stopped. Just bear with us a moment and we'll restart. Okay, I believe you can see my screen again and that the audio is working. Heather, can they just send a chat if people can't hear? Should they can again send a chat message or a question? Okay. Okay. I'm pretty sure we're back on. Okay. Again, I'm sorry. We did lose the audio for a little bit. We believe it's been restored and that you can now see my screen again. So back to the speed and scale template. Again, I'm not sure exactly when we lost it. So let me just cover again, please bear with me, the patient speed section of the implementation table. So the red numbers that you see are the actively engaged commitments that were already made at the PPS or network-wide level. And we're asking each participating partner or site to project out actively engaged by quarter. You may wonder, how is this going to work? Because each of you is sending me your actively engaged numbers, and how will we know that they total to what's given on the screen? The important thing to keep in mind is that the numbers on the screen in red that will be pre-populated on your template, those are the minimum numbers we need to reach as a network. So if the sum of the projections that you make is at least equal to those, it can certainly be greater, and that would be fine. So we don't need you to worry about coordinating with each other to make sure that you total to that number. We're just looking for you to make the best estimate that you possibly can about your site or your project's team's capacity for hospital to home, and give us those numbers. Again, they basically, with this counting methodology, you can think of it as that they reset to 0 at the start of any given calendar year or DSRIP year. And I'll show you a table in a minute that's a reference for how the calendar years align with the DSRIP years. So what you have in your table, you see in DSRIP year 2 by June, by the end of the second quarter, DSRIP year 2 as a network, we're going to have met that definition for a little over 1,000 patients. Then by the end of that same year, that number climbs to 2,743. These are not additive across years. So basically, the following year, in DSRIP year 3, the year begins with 0, but by June, we will have met that definition for 2,616 patients. In other words, that's a little over twice the capacity, or the level of service that was provided during the first 6 months of DSRIP year 2, and so on. The best advice that I can give you is to simply look at those definitions and to make the projections based on your organization's capacity under that project. A common question is this specifically Medicaid patients? Yes, this is specifically for Medicaid patients. In a moment here, the palliative template, basically the same information applies to the palliative template as to the hospital to home. We're looking for the point in time that the different organizations or participants in palliative will have met all the project requirements, and again, the patients that are engaged over time. For palliative, I understand you won't know for sure which of the buckets that you fall into as to clinics, non-PCP, you wonder how those are counted. I will provide you with a table that gives the organizations by type along with your 3 GI template. And DSRIP years and calendar years, here's your reference sheet. Basically, DSRIP year 1 begins April 1st, 2015. It is a short year, it's just 9 months, is DSRIP year 1, and then it just moves on after that into full calendar years. We'll shift gears over to project budgeting. Many of you attended a session in Lake Placid a few weeks ago. There were some budgeting questions that Lynn, our CFO, was able to get some answers to. She's included some more detail in the instructions. So the updated budget template, you can pull it down off of our website. There's also a PowerPoint that walks you through the budgeting process. For anybody who has not taken part in any meetings to date where budget has been covered, I would strongly suggest that you just visit the website, take a look at that template and the instructions that are in it, as well as the PowerPoint. And that information will also be covered in full on Friday of this week. Our CFO, Lynn Wadley, will host a webinar, and it's really the same information she presented up in Lake Placid with just a couple of questions that have already been answered. And she'll be able to walk you through that template and respond to any questions about it. The budget templates are due, again, for each implementation of the project within a given region. Those budget templates are due to AHI on March 13th. And the email address for submitting them, along with subject line project budget, is shown on your screen. One of the important questions that came up when we were in Lake Placid regarding budget was people asked, do I need to prorate staff time in my budget so that I'm really only budgeting for the proportion of time that a given staff person or provider is serving Medicaid patients? And the answer to that is no, you do not need to do that. So we understand that these projects will, while they're designed to meet the needs of Medicaid patients, they're certainly not restricted to the Medicaid population. And you can budget for your staff time in full. It doesn't have to be proportional to the number of Medicaid patients that are served by that particular provider or by that particular project. We are in the midst of defining, who the project champions are across our region. The PPS has benefited from, extensive local involvement and expertise in the various projects, and we think it will be a benefit to the network to have a project champion designated for each individual project. That project champion is really a key leader who would be the subject matter expert in that given program and would provide project leadership really across the network. So there is a scope of work that we're developing. The projected time commitment for a project champion during this first year, because there's so much work to be done with implementation, the projected time commitment is approximately 1 day per week, valued at approximately $20,000 annually. This is a cost that we've budgeted for in the current implementation grant. So you may wonder, we had an early implementation grant that actually expires at the end of this month. An additional implementation award was made to AHI in the amount of $1.3 million, and we would like to be able to fund the time of the project champions during this implementation period. Overall, the project champion would be overseeing the project, monitoring progress. They would participate in any statewide learning collaboratives or forums about that specific project, and would work with the project manager to set meeting agendas and facilitate the meetings. The team would be supported, and the project champion would be supported by the AHI project manager. The project manager at AHI would be handling the meeting planning, the team communications. They'd be able to produce the reports out of the DSRIP tracker, provide any other materials the group might need. We'll be handling the documentation for the quarterly reporting and so on. So lots of project management support. I do not know who the project manager will be for this particular team at this point in time. We're actually recruiting for that position right now. But I wanted to make you aware that we are looking for project champions, and if you have an interest in being a champion at the network level for this particular project, please just send me an email. Here you see some of the key dates in March. We're in a window of time right now where the PPS is able to add partners to the network. The date by which we must do that is March 9th. So we are working now to identify any gaps in the network and to communicate with any practices or partners that are not already in the network that might want to join. So I just wanted to make everyone aware of that. If you know of any partners that want to be part of the network that are not already signed up, don't hesitate to let me know or ask them to get in touch with me. The big dates for you, for this team and the other teams that we discussed earlier today, that's the March 13th date. By March 13th, we will be expecting to see your project budget templates and your speed and scale templates. Again, the budget templates and directions are already available on the AHI website. You can pull those down at any point in time. And today, or if not by the end of the day today, definitely tomorrow, these slides will be posted, as well as the audio for anyone who couldn't take part. We will also post for you the speed and scale template and that reference document where you have the in one place all the numbers that the teams had submitted last December for your reference as you fill out that speed and scale template. Again, the work plans, those are not due until later on in April, until April 22nd. Those work plans are not part of our submission for the April 1st deadline. So we will be submitting a draft of our implementation plan to KPMG on March 16th. Much of that implementation plan is around the current status of developing the governance and the financial model, the technology, in the workforce. So there's, as you can see from today's webinar, there's not a great deal that goes into that implementation plan from the project side that's new or different. Really just a little more detail on speed and scale commitments, as well as there's some narrative description of potential risks to the project and mitigation strategies. And we've hosted a few different meetings and have gotten some of that information from the partners for that draft. We'll then get feedback from KPMG and submit our final implementation plan to the Department of Health on April 1st. So we're just about to the Q&A section. In fact, you can raise your hands and we'll be able to unmute you for Q&A momentarily. In the meantime, I just wanted to mention to you a resource called The Mix. The Mix is a website that the Department of Health has established. It stands for the Medicaid Redesign Team Innovation Exchange. The MRT Innovation Exchange is a platform that the state is using more and more to rely on as they communicate to the PPSs. You create an account, you log in, you can join groups, you can see what other PPSs are doing. It's a place to share resources, to communicate, and there is an option for the PPS itself to create a closed group and to use the mix for internal communications. So I'll be working with our DSRIP support team and to find out a little more about how to go about doing that. So we don't have a PPS specific work group or group on the mix yet, but we expect to. So I would encourage you to go ahead and follow that link and create an account on the mix and start using it. Okay. So with that, we're going to open it up to questions and answers. I'll just wait a few minutes and see if anybody raises their hand. Just click on that little hand that you have on your screen, and once you raise your hand, I will be able to unmute you. So by way of closing, I'm not seeing any hands raising, so I just want to reiterate about the work plan process. Ideally, we do need to develop one work plan that is a high enough level work plan that it's applicable to all the regions. I think that the process for developing that, given that we don't have a project champion or kind of network-wide lead to work with us on that, I am going to stick with what we said on the slide, and at this point in time ask each project implementation within a given region to develop that work plan. Again, that template for the work plan will be available on our website as of March 6th, and that's where you will fill in the steps and target dates and person responsible for doing each of the for meeting each of those requirements. Once we do have a project, project champions identified, it will be, I think, a smoother process to facilitate doing work as a single group. As I said, we are recruiting for a project manager, so we'll get a project manager on board, and we'll be interested to hear if anyone from the partner organizations would like to serve as champion. And once those two roles are filled, we'll be in a much better position to coordinate as a single group things like the high-level work plan. So at this point in time, you can proceed within your regions on your own work plans, and I will keep you posted as to the status of filling those positions. Just making one last check. I don't believe we have any hands raised. So we will close the webinar. Thank you, everybody. Have a good day.